It's my fourth time here, and I mean, this is one meeting I'd come to till I probably retire. So thank you, Sufiano and his team. Thank you, Luis, for inviting me. And let's start. So, you know, when I was asked to do Dolenc's approach and variation, and I saw Dolenc's name on the faculty, I was a bit worried. I thought Luis had great faith in me. So that's Vinko Dolenc. One thing I must always say is that when people used to think cavernous sinus is a no-go area, he is one of the persons who went in and did a transcavernous approach. I mean, it is akin to going through a minefield at that time. So you must acknowledge that he was a legendary path-breaking, and he did that transcavernous approach, after which people started doing it. It's such a useful approach. He also pioneered posterior clinoidectomy, which is one of my favorite topics, and he is a true hero. So tributes to him before I start off with this, what is the Dolenc's approach. Now, how I'm going to plan this talk is that, you know, Dolenc taught us how to take the clothes off, and then we're going to see what is inside. All right, taking the clothes off, the approach as such is celebrated all over the world. And we're going to see that in the lab. I'm going to show you today how we do the Dolenc's approach. So I'm going to show you what we get once we're inside. Why do you need to do the Dolenc's approach? The professor before me, he showed a frontotemporal approach. You can very well get most of the things. If you do a frontotemporal approach, you're going to get most of the stuff. So why do you really need to do a Dolenc's approach? I mean, we know we are all a bit psychotic. On the psychotic side, the neurosurgeons are generally on the psychotic side. So you do approaches just for the heck of it. But is there any point actually doing a Dolenc's approach? That's what I'm going to deal with. So I'm going to go inside, give you a Google Street Map. It's going to be a semi-quiz as well. So we're going to look at some structures. So the structures we're going to identify. Well, first thing first, I must give the credits to whoever. So this was this dissection pictures are based on the tooth dissection in the WFNS Masters, and we were part of it. I was lucky to be part of it. We're going to be identifying the orbitomeningeal band, the anterior clinoid, the proximal and the distal dural ring, 3, 4, 5, 6 cranial nerves and a segmental anatomy, basilar artery and a perforatus, superior cerebellar artery, all the segments of carotid, mammillary bodies, optic nerve, pituitary stalk, posterior clinoid process, and of course an incidental blood aneurysm. One of the things I must always tell you as residents or beginner neurosurgeons, when you start off SKULLBASE, one of the things that you're scared about, in fact, the thing that you're scared about most is the carotid artery. And as you graduate from the carotid artery scared surgeon to the cranial nerve scared surgeon, you're getting better. You know how to handle the carotid artery, you're getting better. Then you're scared about cranial nerves. And then later on, you're scared about retraction. And that's how you graduate. If Luis will tell you how you graduate. So
Sounds good.
This is how I'm planning to take you through. So that's a Google Street Map. Once you're in, you know what are the structures there. So I'm going to plunge in straight. So let's see how many of you can identify stuff here. All right. So what's that blue stuff there? Anybody?
Yeah.
It's going to be an interactive program. I need people to answer me.
No, it's in the background. I think Johnny has
Okay,
kind of...
let me tell you, this is the orientation that we usually take. So this is the operative position. So what's that blue stuff? It's not usually blue in patients, but what's that blue stuff?
I don't know if I'm using because I had that.
Yes, anybody? That's the optic. And that?
Well, no,
that's a carotid. Yes, you're right. And what's that? What is lateral to the carotid?
Well, I don't know. I just see about that.
Come on, guys, open up. That's a third now. And what is that? Huh? Oh, I'm sorry. I'm sorry. I understand why you were quiet. So, yeah. Okay. What is that? Yes. That? Yes. Hey, you're not allowed to answer. You're professor, man. Right. So, okay. So I'm going to take you through this before I lynch you. That's again? Yes? Optic? What's that? Anybody? Huh? Yes, that's a stalk. That's a carotid. That's a third nerve. That's a fourth. And what's that? Yes? The basilar. And what's that structure? Yes, that's a posterior clinoid. Now we're going zooming up. Now there's one structure I wanted to show you. What's that again? That's a third nerve. That's the carotid, right? The optic. What's that? Yes, I mean, Professor Thurer said it. Anybody? Anybody? Okay, let's come back to it. All right. Now you're going progressively inside. We have retracted the carotid out of the way. And so what is that? The posterior clinoid process. You understand why, if you take a posterior clinoid process, it's so easy to get a proximal control for basilar. With this picture, you'll be able to understand a posterior clinoidectomy, how it helps you for basilar control, proximal control of the basilar. That's a third nerve. That is trochlea, fourth nerve. So this is P1. This is third nerve. What is that artery? What is that artery? Anybody? Yes, that's superior cerebellar. We have learned in our MBBS anatomy during our basic anatomy sessions that the third nerve comes between the P1 and the superior cerebellar artery. So that is the other P1. Those are the perforators. This is the third nerve. This is the superior cerebellar artery. That is a PCP. That's a carotid. You have seen the stalk. You've seen the optic nerve. We have kind of seen all the booties in there. Now, I said the carotid is very important. Now you need to understand how the carotid is. I know there are various classifications. I'm going to follow just one simple classification. So there are 7 segments for the carotid. Every odd segment is erect, vertical. Okay? So you have C7, vertical. I'm going to start from the neck region and going to come up. So C7 is vertical. C5 is vertical. C3 is vertical. All right? So you're going to see that. And you must understand the carotid is related to all cranial nerves, directly or indirectly. Everything, 2 to 12, from head to neck, except the 8th nerve, where it is actually related to the cochlea. It's not directly related, but otherwise it's related to all cranial nerves. And unless you drill millimeters within the carotid, you're not going to be a good skull-base surgeon. So you better know what is the structure of carotid. So I'm going to show you. So we said that's the first segment. That is C7. It's a parapharyngeal carotid where the carotid actually gets in. And then you have a horizontal segment. What's that horizontal segment, anybody? The intrapetrous segment. The intrapetrous segment, it comes all the way to the petrous apex, turns up. That is your C5. So you have C7, you have C5. And then at the top of the C5, it gives off an artery. You always find that artery between the 4th and V1. And what is that artery? Anybody? Only skull-base surgeons are going to answer this, I'm afraid. Because this artery is very important, because if you're going to do a tentorial meningioma, that is an artery you need to take first. It'll make your job much more easier. And then comes the C4, which is not exactly horizontal, but yes. And now comes the next vertical segment, C3. And so if you see from the front, let us say an ENT guy is looking at it. You're looking at from the front. So they're not going to see all these segments because those segments are coming towards them. So they're going to see this. You know what they call this? The paracellular carotid. Right. And that is the paraclival carotid. And that is the parapharyngeal carotid. Right? So you have C7, C5, and C3. C6, intrapetrous. C5, cavernous. And that is inside the dura. Very simple. So I'm going to show you various pictures of the carotid, and you're going to identify what part is that. And I'm also going to show you a few things that's going to superimpose on the carotid so that you know in relation. So there's already one nerve there. What nerve is that? We just saw that nerve. That is the third and the fourth. You know, at the petrous apex, there is a ligament. And at the ligament, the carotid turns up. And that ligament is called the petrolingual ligament. I'll be showing that ligament soon. So now you have the Gazerian ganglion, V1, going along with 3 and 4 into the superior orbital fissure. We have B2 going into the foramen rotundum, V3 going into the foramen ovale. You have GSPN. You have Eustachian canal lateral to the carotid. You have cochlea. You have the clivus. You have the PCP. You understand how close the PCP is related to this turn. So if you drill the PCP and you go through it, you're going to injure the top of this carotid. It's very easy. Sometimes that carotid may be lateral, sometimes it may be medial, but it's very easy for you to go through this and injure the top of the carotid. And that's ACP. So you have drawn the carotid first and you have put all the structures around it. Okay? This is the basis of skull base. If you know this, anywhere you want to do surgery, the aim of you to be, when you're going to be skull base surgeons, is to have a 3D, three-dimensional picture of the carotid and build everything around your carotid. And it's very easy. You don't need it to worry. Now, another important concept. How do you do a transcavernous dissection? And for that, the most important structure you must understand is the orbitomeningeal band. So the professor before me, he showed the frontotemporal approach. It comes to the orbitomeningeal band. There's an artery there. That is the only thing that will bleed. Now I'm going to show you a different perspective of the orbitomeningeal band. That's the orbitomeningeal band. So let's say the orbitomeningeal band is a semi-T-shaped structure. So this is medial, this is lateral. Agreed? Yes or no, guys? You must understand that the cranial nerves are here. 3, 4, and V1 is here. So if anybody says cutting orbitomeningeal band is going to harm the cranial nerves? No, it's not going to harm. As long as you don't come all the way here. And if you are neurosurgeons, I believe you will have enough skill to keep it laterally. Now, I mean, this is not exactly correct, but this is my animation. So the cavernous sinus is actually on this side, and the true cavernous membrane is here. If you are lateral to the true cavernous membrane, you will not have much bleeding. If you notice, usually when you have tumors, you won't have much bleeding when you dissect the cavernous sinus. But if you don't have tumors, how do you dissect the cavernous sinus? You need to cut the orbitomeningeal membrane. So that is your anterior clinoid. That is your orbitomeningeal artery. You're going to cut the lateral margin of the orbitomeningeal band. You're going to put your microscope into that. You're going to see a cavity. You're going to see a cavity there because it's a fold. The orbitomeningeal, it is called the orbitomeningeal fold. So you cut that and you're getting in here. And you take this dura up, this dura laterally. If you take this dura laterally, you are dissecting it off from the true cavernous membrane. And believe me, you won't see much bleeding. And plus, your next plus is you are dissecting this dura off from the anterior clinoid process. So you're literally opening up the anterior clinoid process. You don't have to drill the ACP like you're drilling a molar tooth in a small cavity. No, you're opening it up. Today we'll see it in the lab. So you get in here and you dissect. This is very easy dissection. Like Professor Boba says, it's peeling. It's not cutting. It's a bit of sharp peeling. And you peel this, you peel that, the ACP will be opened up for you. And then you have the true cavernous membrane, not much of a bleeding. That's the direction. That's the direction you take. And you open up the anterior clinoid process. And it's a pretty easy anterior clinoidectomy. Yeah, I mean, I always used to say, drilling the clinoid without separating the dura of temporal and frontal lobe is, maybe akin to making love in adduction, which is difficult but possible. Yeah, but so I'm going to show you other pictures with the dural structures in. So guys, yes. What is that? What is that segment of carotid? It's vertical. So what is that segment? Yes? We said all vertical segments, they're odd numbered. So C3, C4, how should C4 be? How should C5 be? Any ideas? Gazillion ganglion, V1, V2, V3. What is that nerve? Huh? The third nerve, yes. You see? We've taken the clothes off. C3, C4. Actually, it's not very horizontal here. I got a bad picture perhaps. C5, vertical again. C6, horizontal. And here, the carotid is dipping down, C7. So you have C7, C6, C5 vertical, C3 vertical. So you have all the V1, V2, V3. You have the GSPN. You have the eustachian, optic nerve, 3, 4. Can you show me the sixth? Anybody? The sixth is always found medial to the V1. So where is V1? That's V1. What is that ligament? Anybody? Beg your pardon? Anybody? What ligament is that? Yes, that's the Grubus. And That's the Dolenc canal, and the sixth is coming in here, medial to the V1. Okay? So that is the picture that you will get. Today, we will see. And this is looking at it from anterior. So you have the paracella carotid, the paraclival carotid, and you will have the parapharyngeal carotid here. These are all vertical segments. So C7, C5, C3. That's what the ENT guys will see. Usually it's like this. The ENT guy sees from the front, we see from the side. We don't know what they're looking at, they don't know what we're looking at, but it's the same picture. I just wanted to show you some pictures to stress this part. Right. Okay, let's go again. What is that segment? That's a C5. Right. So what is that nerve? Sixth nerve. Very good. I see a lot more guys are answering now. That is, what is that? Not you. Keki, not you. V2. That's a gazerian ganglion. Right. So 3, 4, C5, C4, C3 comes, C3 comes up again, vertical again, and C6 would be here, horizontal. Right. So we see the C6. And what's that now? What is that now? We showed it in the animation. So now C6, the petrolingual ligament, C5, and then C4 comes here, and we talked about that artery. 3, 4, part of V1 is cut. The nerve which is coming medial to V1 is the sixth nerve. Now that's your homework. That is what you should photograph, and that is your homework, because no lecture is complete without a homework. If you don't go and read it for yourself, this lecture, there's no meaning. Any lecture, there's absolutely no meaning. Now, this is a work which has influenced me a lot. You know why? You see only white, you see different figures. And you start seeing the black, you see different figures. Actually, this picture is the fusion of both. Life, neurosurgery, everything is like this. You must understand, one approach, you see it different times, do it 100 times, you will learn furthermore. If you think that you have done 1,000 surgeries, on the 1,001 surgery, you will learn something more. You will learn that, yeah, there is this figure. So this mosaic is about your neurosurgical career, your learning in your neurosurgical career. The day you see this complete, that there is a fish here, there's a kangaroo there, snail there, you start seeing everything together, that is when you go towards completeness. Completeness is a very difficult thing, but you keep learning. Any day you think that I know this figure, that's the end of it. Well, I just wanted to show you the incidental bleb aneurysm. Those are the mammillary bodies. That is, we are extending it into the, we are extending the Dolenc. So we are extending the Dolenc. So we've done a petrosectomy also. So you can see now the P1, that's the third nerve, superior cerebellar, the fourth nerve. You can see the fifth, you can see the lateral brainstem. Literally, you can come from here to all the way there. So that's the beauty of this approach if you combine with an anterior petrosectomy and tentorial cutting. So we did this dissection in France. Now, variations of the frontotemporal approach and Dolenc is like Kama Sutra. You have common and uncommon positions, pleasant and unpleasant positions. but you don't want to end up with a position like this. Okay, this is one thing you need to avoid, because a lot of skull-based surgeons finally, you don't want to end up with this. And I always, I like this picture a lot, because, at the end of the day, we show a scan and people say, oh my God, wow, you done this. But this should not be the picture. You should not have a tumor chasing you to walk on water. I mean, if you're walking on water, walk on it without this calm, quiet, okay? You should not have a situation where the tumor chases you and you have to walk on water, okay? Thank you.